Okay.
This meeting is being recorded.
Okay, so good afternoon, everyone. So thanks, Islam, for inviting me to this meeting, and thanks for the Egyptian Society of Radiology and Bena University and Dr. Hisham for inviting me to talk to you today. So we are going to talk about MRI of primary liver neoplasms. It's an introduction to basic liver neoplasms and how they look on MRI. So there is nothing to disclose. So what we want to talk about today is what does a basic MRI sequence look like? Whenever we read an MRI of the abdomen, any MRI, first thing we have to know what the sequence we're dealing with, okay? So that we know why this particular lesion look this way. Other than that, we're gonna talk about the bread and butter liver neoplasms in adults. I'm not gonna get into pediatric masses, it's just the adult liver neoplasms and their characteristics on MRI. Okay, I want you to, I think Islam told me that you can actually use this poll everywhere. So if you want to log in to this site, and the username is Ines Mohamed 291. The way we're going to go is that I'm going to show you a case, okay? And then after that, there will be the poll slide, and you can put in your answer as you wish. It can be anonymous. You don't have to put your name in. Just give your best answer. And then we are going to discuss the diagnosis, okay? So this is actually our first case here. I'm going to be nice and just tell you what the are. So this one here, this is a T2 weighted image. As we see, the spinal fluid is actually bright. So this is T2. This is actually the lesion we are looking at. So this is T2 fat satted, okay? The fat is dark here. And this is T1 pre-contrast, right? The same lesion. And here, this is what we call a late arterial phase. For MRI of the liver in particular, we like the late arterial phase. So you have early arterial, late arterial. The late arterial is actually where the liver enhances better. It's around like 25 to 30 seconds post-contrast injection. This phase sequence here is actually the portovenous phase. It's around 70 to 80 seconds post-contrast injection, and this is the delayed. Delayed is usually for like the routine MRI, it's usually 5 minutes to 8 minutes post-contrast injection. With other contrast agents we're going to talk about soon, we can go up to 20 minutes post-contrast injection. So look at this and tell me what your best diagnosis is. And I hope the poll everywhere is going to, so here it is. If you can put in your answers. Sweet. Okay, is this everybody? Okay, nice. So you got the right answer. This is a hemangioma, okay? So what does a hemangioma look like? We call it a light bulb on T2. So again, what's common is common on MRI. You know, the most common lesion that you're going to see in the liver is actually a cyst, right? Second common is going to be a hemangioma. We like this T2 signal. If we're going to go back here, we call this a light bulb, okay? A bright T2, it's usually T1 hypo intense. And the most important thing when you look at the hemangioma is that it has, on the post-contrast, the gadolinium, it has a discontinuous peripheral nodular enhancement with progressive centripetal filling. It's not allowed to fill in from inside out. You have to see it progressively, and it has to be a discontinuous peripheral nodular enhancement. There is another contrast agent we we use, which is the Eovist. Eovist is actually a hepatobiliary agent. Simply, the liver deals with it like it's bile. Okay, and in the hepatobiliary phase, which is actually 20-minute post-contrast, the only thing that's going to retain the contrast on this sequence is going to be anything that has bile in it, anything like focal nodular hyperplasia and stuff like that. So Eovist is actually a contrast that we use for problem solving for only certain issues. One of them is focal nodular hyperplasia. We can use it also for metastasis, follow-up metastasis in cancer patients, or we can use it actually if there is a bile leak and we want to know if this collection is actually bile or something else. Okay. There is another, you can call it subtype or another imaging appearance. It's called a giant hemangioma. It's actually more than 4 centimeter. It has a central scar, a T2 hyper-intense scar and T1 hypo-intense scar. Again, the giant hemangioma, the same enhancing pattern, peripheral nodular discontinuous enhancement with progressive centripetal filling. The central scar does not enhance. So I have a question if somebody wants to unmute themselves. If you have a 5 centimeter lesion with peripheral continuous enhancement and on the progressively it enhances heterogeneously, like it fills in centrally and it doesn't follow this pattern of hemangioma, what do you think that will be? Who is the scary cousin of hemangioma, as you would say? Anybody? Anybody have an answer? Okay, yeah, go ahead. I mean,
I think cholangiocarcinoma is the first possibility.
Yes, cholangiocarcinoma. Cholangiocarcinoma, good answer. It is actually the scary cousin of hemangioma. So whenever you look at a hemangioma, it's not that high, like you think. It's a little bit T2 hyper intense. We call it the evil gray. It's not really that hyper intense on T2. And is this a hemangioma? Not a hemangioma? Always put in the back of your mind cholangiocarcinoma, and we're going to talk about that later on. Okay, the other one is the flash filling hemangioma. This small T2 markedly hyperintense lesion, hypointense, but on the arterial phase, it just promptly enhances, and there is no washout. Washout is another important terminology, meaning that that thing does not lose enhancement, doesn't look hypo-intense relative to the liver on like subsequent post-contrast sequences. Okay, this is our second case here. We're talking about this lesion there. Okay, so the key here is actually to know the contrast. I'm gonna just, this is T2 non-fat sat. This is actually T1 pre. This is the arterial phase, and these two are delayed. So just look in here and tell me what this lesion is. Okay, I'm going to give you a second, and then I'm going to give you the what it might be. Angiocarcinoma. Okay, anybody? We're all over the place. Okay, fine. Okay, 20 vascular carcinoma. Okay, changing our mind. Okay. Okay. Angioadenoma focal nodular hyperplasia. Okay, so again, this was a little bit sneaky because that contrast is Eovist. Okay, so I mean, if you wanna, I'm just gonna put this a little bit. So so this is T2, so it's kind of a little bit hyper intense. Arterial, it's very enhancing, and I understand why some would call it like hepatocellular carcinoma or even an adenoma, you know, but that contrast is actually EUVist. Okay, so what did this lesion do on the hepatobiliary phase, which is actually 20 minutes? See, there is nothing enhancing except that structure. That structure is actually the bile duct. Okay, and this lesion there actually retained the contrast. So this is actually focal nodular hyperplasia. We call it a stealth lesion. Sometimes you don't even see it on any sequence except this one, except the arterial. It just stands there. I know we know it by the central scar and all that stuff, but sometimes it doesn't have that. And we are gonna talk about that in a second here. So focal nodular hyperplasia. On T2, it's slightly hyperintense to iso-intense. It has a central scar. This central scar is hyperintense on T2. On T1, again, you might not even see it. Because what is focal nodular hyperplasia? It's actually a hamartoma of the liver. It's just a bunch of hepatocytes and bile ducts in a weird arrangement. So on T1, it's usually arterially enhancing. It has this marked homogeneous arterial enhancement, and the scar actually progressively enhances. The one thing that actually catches the focal nodular hyperplasia, if it's not really typical, like the case we just showed you, it wasn't really that typical, you know. That's why we told the clinicians, okay, now I'm thinking, I don't know if this is FNH, if this is an adenoma. We told them to get an EUVist, and they got the EUVist and retained the contrast on focal nodular on the hepatobiliary phase, which, as we said, 20 minutes post-contrast injection, and this is focal nodular hyperplasia. Okay, atypical focal nodular hyperplasia, the one that doesn't have a scar. This is usually for smaller sizes. The one that has multiple scars. And I want to just, I don't know if you know about the in phase and the out of phase. We're going to talk about that in detail in a second. So as we said, the focal nodular hyperplasia is actually liver cells. They are liver cells in weird arrangement. So if the liver, sometimes if the liver is fatty, that lesion is going to be fatty, you know, is going to have intracellular lipids. So it might drop the signal in the out of phase, just like the rest of the liver, okay? And sometimes if the liver, if there is hemochromatosis, the focal nodular hyperplasia might drop the signal in the in phase, just like the rest of the liver. This is just something to keep in the back of your mind. Is like, it doesn't mean that, oh, the lesion is dropping the signal, it's something else going on. No, if it's a focal nodular hyperplasia, it's just gonna follow whatever is going on in the rest of the hepatic parenchyma, okay? Another something to have in your pocket is, what are the lesions that have a scar? Not just focal nodular hyperplasia. Fibrolamellar carcinoma, it's a very hideous cancer in young males, and we're going to talk about it in a second, can have, of course, a central scar. Cholangiocarcinoma can have a central scar. Hemangiomas, just like we said, the giant hemangioma can have a central scar. HCC can have a central scar, and it's more likely in like necrosis, not a real scar. Okay. Okay, so this is a fun case, as you say. It all depends on what is the sequence. Again, we have to know what sequences we're dealing with. And I'm talking about these lesions in there, these ones, okay? What do you think that is? Okay, I'll give you a second to look at it, and then I'm going to show you the options. Okay, okay, I love that. Okay, so okay. Okay, so come on, go back. I'm just having issues moving. Sorry, just have to. Okay, I just wanted to go back. So perfect. This is actually focal fatty sparing. See, this is actually the out of phase, and this is the in phase sequence. Okay, I know we're talking about primary neoplasms in the liver. This is not a neoplasm. It's just, I want to introduce this sequence to you, the T1 out of phase and the in phase. So what happened here actually is that the whole liver dropped the signal, except these little lesions there. See, they did not drop the signal. So what's happening is that the liver, there is focal fatty infiltration in the liver, this marked focal fatty infiltration of the liver with areas of focal fatty sparing. Okay. So in short, I'm not going to get into so much details. What we are looking at here is like, imagine a circle with two runners in them, okay? One that's really fast, which is the water, and one that's slow, which is the fat. Every 2.2 milliseconds, these two runners are either out of phase, like opposing each other, so we don't see a signal, or after another 2.2 milliseconds, they are in phase, so we see the signal. So in the out of phase, if you have this intracellular lipid, okay, you are going to lose the signal, okay, because these two runners in the voxel or in the circle are out of phase, opposing each other, okay? So this is basically what the in and out of phase is. This is the other case here. So we are talking about these lesions there, if you can see that. Okay. So this is a T2 non-fat SAD. This is T1 fat SAD pre-contrast. This is the late arterial phase. This is the portovenous phase. This is delayed. And I just want to tell you, want you to look at that. Okay. And tell me what you think. Like you can just look at this one and just, they're all the same. Okay. What is that? Okay. Okay. Okay, perfect. So actually, these are adenomas. See, we have two tricks in this case, or the main thing that grasps an adenoma is the T1 hyperintense signal. Okay, there are different subtypes of the adenoma, and we're going to talk about that in a second, but this T1 hyperintense signal in a normal looking liver, that liver doesn't look diseased. So we have this T1 hyperintense signal, okay, and this is the arterial phase, it's arterially enhancing. It did not wash out. A lesion that, this is actually, of course, EFS, this is the hepatobiliary phase, this is different from the case that we just saw. Losing the signal in the hepatobiliary phase is not washout. Okay, if you lose the signal, all of the lesions we are going to discuss, hemangioma, cholangio, everything is going to lose this, like like lose the contrast except focal nodular hyperplasia. And there are other like other differentials. We're not going to get into that, these zebras right now, but are going to lose the signal. So this is not washout. This is just the lesion did not retain the contrast because it doesn't have bile ducts and hepatocytes. Okay, so this is actually an adenoma. Okay, so adenoma this is generally T2 mildly hyperintense, T1 it can be hypo, or hypointense depending, does it have is there blood or not. In the in and out of phase, it can have signal drops. Sometimes adenomas have intracellular fat, and on post-contrast enhancement, it has early arterial enhancement, but it does not wash out. Actually, if I know this is a hemangioma, and this is a reason why we keep following these patients, like young females with adenomas, is that there is, first of all, there is risk of bleeding. Okay, the patient can come back with bleeding. The other thing is that there is a chance that it can turn into HCC. So if you see a washout in a lesion that you know it's an adenoma, this is kind of a red flag. Okay, on the EOVIST, it's hypointense.
لو سمحت دكتوره ناس، ممكن بس تعليق صغير. واحنا عندنا في مصر مش بنستخدم ايوفيست، فالناس مش عارفه قوي ان هي بروتين كونتراست اونلي فور اتش سي سي، فحضرتك ممكن توضحي لهم بس الايوفيست يعني. اوكي.
طيب so EOVIST it's a hepatobiliary phase, hepatobiliary agent. What it does is it actually the liver deals with it like bile, the way it, like, imagine that this is just bile. Okay, so first of all, to use EOVIST, we need good liver function. So if the liver is cirrhotic, okay, I can't use EOVIST, okay, or the patient has bad liver function, he can't actually use it. We can't use it, okay? And we have to go to something we call the hepatobiliary phase. The hepatobiliary phase is actually 20-minute post-contrast. On this phase, everything is gonna lose the contrast except bile, which means the bile ducts are gonna be contrast opacified. The bowel, like the duodenum, is gonna have anything that has bile in it. Okay, the lesions that actually always have like is gonna retain the contrast on the hepatobiliary phase or gonna appear hyperintense on the delayed hepatobiliary phase is actually, number one is focal nodular hyperplasia. Okay, there are differentials there to it, which is actually if it's a very well-defined HCC and still have some normal appearing hepatocytes can appear, but just for the basics, the only lesion that retains the contrast in the hepatobiliary phase is the focal nodular hyperplasia. Okay, like simply put, that's it. And I have another slide for the EOVIST. I'm going to talk about it a little bit more for when we get to the HCC, but that's it for now. Okay. So we are talking about adenoma. Okay, so there are certain subtypes of adenoma, HNF1 alpha, beta catenin, inflammatory, and the unclassified subtype. So the first one we're going to talk about, which is the most common, is the inflammatory hepatic adenoma. On T2, it's markedly hyperintense, and it can have a rim of T2 hyperintensity around it. We call it the atoll sign. On T1 can be also hyperintense, secondary to hemorrhage. This inflammatory hepatic adenoma does not drop the signal in the in and out of phase. Okay, so not all hepatic adenomas look the same on MRI. Okay, so the inflammatory subtype is not going to drop the signal in the in and out of phase, it doesn't have intracellular lipid, but it's going to look T1 hyperintense. Okay. On post contrast, of course, it arterially enhances and it persists on the subsequent phases. The other subtype, which is the hepatocyte nuclear factor 1 alpha, this is 35% of the subtypes of hepatic adenomas. And this is the one that has intracellular lipid. This is the one that will drop the signal in the outer phase compared to the in phase. Okay, in T2 is going to be moderately hyperintense, and the same thing, arterially enhances and becomes isointense without washout. Okay. This is the one why we do biopsies for adenoma, okay? And this is going to be your atypical presentation, the male with glycogen storage disease, or he's on androgens, or, you know, this is the one that's most risky for developing HCC. And if we are gonna, like, when you have a male and it doesn't fit like the female on contraception, all that stuff, and you find an adenoma, this is the one you should watch for. Okay, beta catenin, T1 and T2, it can be homogeneous or heterogeneously hyperintense. It does not signal drop, and it can have heterogeneous arterial enhancement, which becomes isointense or hyperintense on delayed phases. On the washout, if again, any hepatic adenoma, she comes for a follow-up or he comes for a follow-up, and you start seeing rapid increase in size or and washout, always put in the back of the mind there might be malignant transformation. Okay, and then there is the unclassified. Again, it's just a subtype, and quite frankly, it's a pathologic subtype. It does not. It's the T1 mildly hyperintense, and it looks exactly the same. These are all just pathologic subtypes. When they biopsy the adenomas, they want to know what subtype it is and does it have a beta catenin component in it. Okay. Hepatic adenomatosis, which is actually the case that we kind of looked at right now. This is the patient who has more than 10 hepatic adenomas, and this is the one that more susceptible for hemorrhagic transformation. And that's why these patients can present to the emergency department with acute abdominal pain, and she does a CT and she's bleeding. There's subcapsular hematoma in the liver and all that stuff. Okay. Okay, so this is our next case. Look at it. So this is, again, just this is T2 weighted image, T2 fat SAT. This is actually diffusion. Okay, this is ADC map. This is a beautiful sequence. So this is what we call the high B value diffusion weighted image. This is its ADC map. Okay, and then this is the pre-contrast. This is the early arterial, and this is the portovenous. And we just, I mean, this patient has more than lesion than that, but just focus on this one. Okay. Okay. Actually, it is hepatocellular carcinoma. So look at the liver. That's a cirrhotic liver, right? Look at the spleen, the liver. That liver is cirrhotic. It's miserable in there. It's it's nodular. It's you see the ascites. See this T2 signal there? There is fluid. The liver spleen is big. So this is a cirrhotic liver. Okay, and quite frankly, even if you're looking at MRI, you're looking on ultrasound, anything in a cirrhotic liver is HCC until proven otherwise. Because what happens is, as the liver gets shrunk, you know, with cirrhosis, it loses its beautiful cysts and hemangiomas and all that stuff. Again, anything in a cirrhotic liver you have to put in your mind reading ultrasound. It looks hypoechoic on ultrasound. It looks hyperechoic on ultrasound. It looks ISO. Anything is HCC until proven otherwise. I mean, you have to put it in the back of your mind. And we're going to talk about the LIRADs in a second here. Okay. So yes, this is of course HCC, right? This is the same patient, and I just want you to look at this structure in there. This was multifocal HCC actually. This is a diffusion weighted image here. So this is a high B value DWI. Usually we can go up to B value of 600 or 800 in MRIs of the liver. This is the ADC map. This is the arterial. Actually, that thing was necrotic, you know, and this is a washout. What is that? Anybody want to unmute themselves and tell me what is this structure? Yes, go ahead.
I think this is a right portal vein invasion.
Yes,
malignant
exactly.
thrombus.
Perfect, beautiful. So this is actually what we call tumor in vein. Okay, and this is beautiful. Actually, we're going to talk about the LIRADs in a second. You have LIRADs like the ones we worry about is 3, 4, 5, right? And you have this separate category, which is tumor in vein. Okay, if you are thinking, let's say that thing actually does not really follow the usual arterially enhancing delayed washout, just the fact that the thrombus, and it's a tumor thrombus, it's not a bland thrombus. This is a tumor thrombus. It's restricting just like the tumor it's coming from. Okay, the fact that you have a tumor in the portal vein, tumor thrombus in the portal vein would make you just, oh no, it's not cholangiocarcinoma. It doesn't do that. And we have certain neoplasms in the abdomen that actually loves going to the vein. Like, let's say you have this infiltrating lesion in the kidney. And is this infiltrating renal cell carcinoma or is it urothelial carcinoma? If it's going to the renal vein and the IVC, most likely this is going to be RCC, infiltrating RCC. Again, if you have an adrenal neoplasm and it's going into the adrenal vein, it's going into the venous system, it's actually adrenal cortical adenocarcinoma until proven otherwise. So you have to keep this tumor in vein. Sometimes actually in the literature, they wouldn't find a primary tumor, like the liver is just like heterogeneous all over. Does he really have like infiltrating HCC or is it something else? If there is a tumor thrombus in the portal vein, it's HCC, it's done, okay? So hepatocellular carcinoma, as we said, it's a cirrhotic liver. And I just want to throw in there, if you have a patient that has a history of hepatitis C or hepatitis B virus, and the liver looks okay, holding itself on MRI, that history of hepatitis B or hepatitis C, it doesn't, like what I mean is, it doesn't have to be cirrhotic to actually call it HCC. It might just have a history of some kind of insult to it that will predispose this patient to have HCC. Okay, on T2, it's a mildly hyperintense. We call this the evil gray. When you look at the T2 hyperintense, and it's kind of like this little bit hyperintense, it's evil, especially if this patient is cirrhotic. On T1, it can be hypo or iso. On again, arterial enhancement, rapid portovenous washout, very important. Okay, and persistent rim enhancement, which we call the capsule. This is the washout and the capsule are important in the LIRADs, and we're gonna talk about that. Okay, it loves invading the portal vein. I mean, it can be hyperintense on EOVIST. I mean, we just talked about that. It can be hyperintense if it's well differentiated HCC, but this is a zebra. This is kind of very rare. Okay. And on diffusion weighted images, diffusion is a beautiful sequence. You know, quite frankly, every time I'm reading an MRI of the abdomen, I have to check diffusion before I actually sign the report, because it's not specific, but it's very sensitive. It can grab your attention to, oh, I missed this lymph node, I missed this lesion in the bone. It's just a beautiful sequence, and hepatocellular carcinoma restricts like crazy on diffusion. Okay. So this is the LIRADS, okay? Actually, Dr. Sais, he's Egyptian too. He's a professor in MD Anderson in Texas. He's doing a great job like for this LIRADS. I mean, I'm just showing you this to just show you that one of the criteria, like other than LR1, LR2, is actually a definite tumor in vein. Okay, I just want you to look at this table down here. When you want to apply the LIRADS, the main thing you want to look at is that observation, is that lesion we're looking at, is it arterially enhancing or not arterially enhancing? Okay. If it is arterially enhancing, so the next thing we're going to look at is actually the size. Is it like, let's say, less than 10 to 19 millimeter, more than 20 millimeter? Okay. And then the major features upon which we say, is that thing actually like this non-1-2, the major feature we apply the LIRADS to is actually the enhancing capsule, the non-peripheral washout, the central washout, and the threshold gross. Threshold gross means that this patient had an MRI before, and I'm comparing the size, and it's kind of like increasing like 50% within 6 months. Like if I have a lesion that 6 years ago, it increased 1 centimeter, that's not threshold growth. Okay, it's a beautiful paper, and this is actually the paper I got it from by Dr. Sais. If you want to read it, it's about the LIRADS. It's very important if you're going to look at MRIs for patients with cirrhosis. Okay. Here is the IRIST. We talked about that already. It's an extracellular gadolinium contrast agent. We usually apply 5 phases. We apply the late arterial, the portovenous, what we call the transitional, and the hepatobiliary, which is 20 minutes. These are the main phases we get. You have 2 problems with IRIST, is that, as we said, it needs a good liver function test. Sorry, like the patient doesn't, you can't use it in a cirrhotic patient, okay? Because it needs the liver to use it, like uptake the contrast and then excrete it, okay? The other thing is the patient, when they get IRIST, they have this physiologic thing that they get tachypnic, so that you actually get respiratory motion in the arterial phase and you lose the arterial phase. So if we lost the arterial phase, it's a really big problem for us if you're looking for HCC in a cirrhotic patient. So anyway, long story short, we don't use IRIST for cirrhotic patients. When they did the LIRADS, they did not use it for IRIST. LIRADS was used for the usual gadolinium IV contrast that we all use. Okay, this is another case, and of course that's a CT. Okay, and here is T2 hyperintense, T1 pre-contrast. Sorry, not T, I mean, this T2, this is T1, this is the early arterial, late arterial, and this is delayed. So I'll let you look at it for a second. Okay. Okay, we're done. Okay. This was a little bit tricky, I want to say, because I didn't put the right term. I just put hepatocellular carcinoma. If I give you a history for this guy, this was this here CT was for a 19-year-old male who came in trauma to the emergency department. He was an accident. He came in, and we saw that thing with a calcification in it. And then, as you see here, T2, it's heterogeneous. We have here this central scar in there, and it's kind of progressively it is enhancing. There is progressively enhancing, and the scar is actually hypo enhancing on the delayed phases. Actually, this was fibrolamellar HCC. I understand if you put cholangiocarcinoma in there, yeah, it might be, but just I wanted to show you the CT cause of the calcification. A healthy liver with this calcification in there, fibrolamellar HCC have to be on the top of your differential. Okay, so it's a large mass with a central scar. It's a young adult with no liver disease. Again, it's going to be mildly hypointense scar with calcifications. T1 hypointense, and the scar is hypointense. On post-contrast enhancement, you're going to see this heterogeneous arterial enhancement. It's not going to be like your usual HCC. Fibrolamellar HCC is a very, very aggressive neoplasm, and unfortunately, this patient passed away. It's a very, very ugly neoplasm, and especially if you have a young male in there, always put it in the differential. Okay, the scar does not enhance. Okay, and of course, you're going to see other features of malignancy. It's going to be invading vascular or biliary invasion, and UVEST, it does not show uptake. I think somebody was talking. Okay. Okay, so this is another case there.
Excuse me. So, one question from the chat box. Someone is asking why not giant hemangioma?
Oh, why not giant hemangioma? Okay, let's go back. Okay. Okay, so first of all, look at this. Like, this is not the light bulb, right? Yes, it is in the differential of the central scar. This is not a light bulb. That's not your peripheral discontinuous enhancement, right? Hemangiomas don't have calcifications, and it's just very aggressive for a hemangioma. I mean, I understand sometimes it can a giant hemangioma can be an issue too, but just this signal and the way the necrotic scar looks like, this is not really a hemangioma. Okay, it just looks malignant. I mean, I would understand why somebody would say cholangiocarcinoma, but benign hemangioma, it doesn't fit that. Okay, we're looking at this thing there. So this is T2 coronal hyperintense. This is T2 axial hyperintense. This is T1 pre. I apologize. There is a big, the patient had surgery in his stomach, and there was a big artifact there, but we can still see the lesion, I guess. So this is arterial, okay, and this is portovenous, and this is delayed. I will give you a second to look at it and then go from there. Okay. Okay. So, actually, this is cholangiocarcinoma. I mean, this is, look at that. Look at what's going on there. This is crazy. Like all these T2 hyperintense linear like ducts there. This is actually intrahepatic biliary dilation. you know, and it's just the cholangiocarcinoma is really a fibrotic lesion. Sometimes it's just fibrous tissue, you know, it doesn't enhance except very, very late. I mean, I'm showing you the full-blown cholangiocarcinoma with invasion of the bile ducts, but again, I want you to keep intrahepatic cholangiocarcinoma. It's very tricky. The one that just started, that's kind of very, very delayed enhancement even without the bile ducts enhancement. You have to put it in the differential, okay? But this one is kind of full-blown cholangiocarcinoma. That infiltration of the bile ducts is you see, it just grabs your diagnosis. So we have two types of cholangiocarcinoma: the intrahepatic cholangiocarcinoma and the extrahepatic. Actually, extrahepatic is much more common. What we just showed now is the mass forming. We have the Klatskin tumor, Klatskin cholangiocarcinoma, which is periductal, and you have the intraductal and the large extrahepatic cholangio. On T2, it is again moderately, slightly hyperintense. It can have a central scar, which is necrosis. On T1, it's hypointense. T2, very delayed enhancement. Actually, in our protocol, we have the routine MRI, which is kind of like our usual pre-contrast sequences, and then the post-contrast sequence up to 5 or 8 minutes. And we have the cholangiocarcinoma protocol, which actually goes in the enhancement till 15 minutes. Cholangiocarcinoma is a fibrotic, just like a fibrotic tissue, so much fibrosis that it actually can just stay there, minimally enhancing until very delayed, 15 minutes. Okay. Again, cholangiocarcinoma restricts like crazy because it's like restriction, you know, as you know in physics, is this Brownian motion. If it's just all fibrotic tissue in there, you lose this Brownian motion. Actually, we have seen cases where you see cholangiocarcinoma on the diffusion weighted images. Okay, and sometimes it has this peripheral hyperintense or target appearance. It's not really common appearance on diffusion. Of course, the bile duct dilation grabs the diagnosis, and sometimes since it's very fibrotic, it causes a retraction of the liver capsule. Okay, this is another case. This is a tough case. Actually, we didn't get the diagnosis. We put a differential for this case when we saw it, but we didn't grab the diagnosis except with after biopsy. So this is, I want you just to look at this and look at that. So it's not just one lesion. And T2 slightly hyperintense, and look at the diffusion here and look at how it's enhancing. And there is another subtle finding in the images. If you can see it, you will get the diagnosis, but a subtle finding outside of the liver. Okay, I'll give you a second to look at it. Okay. Actually, this is very good. This is actually lymphoma. It turned out to be lymphoma. We have given them actually quite a differential because she was an otherwise like a patient who presented actually with fever and stuff. so it wasn't, we've put in the differential lymphoma, but even it wasn't on the top of our differentials. The subtle finding is actually there's something happening in the spleen here. So you have both splenic and hepatic involvement. And the other thing, I don't know if you're gonna appreciate that thing is not like, they are huge, and they are not really invading anything. It's just pushing the vessels around, which is actually a very peculiar thing for lymphoma. You can even look at the small bowel, and there is a humongous mass in there, and it's just not doing anything. There's no even bowel obstruction. So lymphoma everywhere looks the same. It's just it has this mass effect, and it very, very rarely actually causes any obstruction or invasion. So this was actually lymphoma, and I want to show you PET CT for this case. Crazy, just crazy. FDG AVID PET CT is beautiful in cases of lymphoma. Look at all this activity, and this patient also had some lymphadenopathy, which would help with the diagnosis. But again, if there's cancer, you will have lymphadenopathy. So, but the spleen was kind of an add. Made it easy. Okay, so lymphoma, most likely it's secondary, so the involvement of the liver is secondary. 50% with non-Hodgkin lymphoma, 20% with Hodgkin lymphoma, there is liver involvement. Primary hepatic lymphoma is actually rare, less than 1% of all non-Hodgkin lymphoma cases. Lymphoma has different patterns. And by the way, this is actually how it looks like in the kidney. If you have renal lymphoma, this is how it's going to look like. In the spleen, either it's diffuse infiltration, like you just see hepatomegaly and crazy uptake on PET CT, or it can be these multifocal hypo-enhancing masses, or it can be a solitary mass, just one mass somewhere, or sometimes it shows the periportal infiltrative, just periportal infiltrative mass, which is more likely in the PTLD or the post-transplant, like lymphoproliferative disorder. This is the periportal infiltrative pattern. Okay. So what we just saw is a mass-forming lymphoma, T2, slightly hyperintense to iso-intense. This one was a little bit more hyperintense. That's why it just it messed us up. We didn't just put the diagnosis. The T2 signal for this mass was kind of more than we expected for a lymphoma. Lymphoma is usually these subtle T2 hyperintense lesions, but as we always say, the masses, like the lesions, don't read the books, so it doesn't usually follow what's in the book, the criteria. Okay, T1 hypointense to iso-intense. On post contrast, it shows minimal to no enhancement on all phases. Diffusion is crazy, it markedly restricts. And what we talked about is a vessel penetration sign. You can even see the vessels going in between, coursing through the lesion. And you can have simultaneous involvement of the spleen. This is a fun case. This is the last case of our talk today. It's fun. I'm just putting arrows there to tell me what's going on. This is all the lesions. All these arrows is actually on the, like what is going on there, okay? And see, like this is actually T2 hyperintense, these two coronal T2. This is axial T2, this is diffusion. Look at what's going on there. And this is pre, this is arterial, and this is post, like delayed, sorry. And look at all this stuff going on. This is just for fun. Okay, I'll give you a second to look at it. Okay, and tell me what you think. Okay, I like that. So it's splenosis. See, we don't have the spleen. So that's what grabbed the whole thing, quite frankly. When I first opened this case, I was like, oh my God, this peritoneal carcinomatosis in this patient who doesn't have any symptoms. And but it actually, just with the history, this patient had trauma, they had to remove his spleen, and this is just shattered like splenials everywhere, as if you would say, and some of them sometimes actually implant on the like liver and other organs. And a more sneaky way to show it would be on PET-CT, because spleen sometimes show uptake, and it can be just this hyper intense lesions everywhere. But the most important thing is always look at the spleen. Okay, so this was splenosis. In the liver can be well-defined subcapsular lesions, T1 hypo to T2 hyperintense, homogeneously enhancing, restricts, and follows appearance and enhancement of normal spleen on all sequences. This is my references, and that's it. Thank you.
Any questions? Dr. Ines, ممكن تبصي على chat box. They would like to thank you. And a question: why we cannot differentiate types of cholangiocarcinoma by radiology?
The subtypes of cholangiocarcinoma?
I'm not sure. Yeah, okay.
Yeah, I mean, you mean intrahepatic or extrahepatic, and yes, of course. I mean, you can see a Klatskin tumor like this infiltrative neoplasm with intrahepatic biliary dilation, maybe going towards the left, and sometimes you will have both types. Yeah, like you will have a mass in the liver, like intrahepatic and extrahepatic. It's just because our talk today was about hepatic neoplasms. That's why I didn't get into the extrahepatic portion of the cholangio. But yes, of course we can. I actually can't see the chat. So, oh, here it is. Okay. Any other questions, Islam?
Yes, someone is asking, I could not understand the case of fibrolamellar HCC. Why not cholangiocarcinoma?
Yes, well, it's in the differential, but first of all, this is, as I said, this was a young male, and this is a large lesion with a necrotic central scar. It's heterogeneously enhancing of the arterial phase and then washing out. So actually, we didn't give a differential for this case. It was actually the only differential, which is not in this case, for fibrolamellar HCC would be focal nodular hyperplasia. But of course, this looked too angry for focal nodular hyperplasia and the calcification and all that stuff. But yes, I would consider cholangiocarcinoma, but given everything that was around this case, my number one was. And other thing I want to tell you, a mass that big and no intrahepatic biliary dilation is extremely rare. Like if you have a cholangiocarcinoma that big and the bile ducts are perfect, it's kind of like, no, I wouldn't go there. I wouldn't go for cholangiocarcinoma.
Another question, so about adenoma, what's the precautions for biopsy from adenomous lesions?
Precaution for biopsy. I mean, I don't think, like, you mean
the question was, okay, so when do you biopsy adenomas? Any precautions? This is a question.
In our institute, they biopsy it all the time, actually, for two reasons. They don't want to miss another diagnosis, and they want to know the pathology. Because you see, there is inflammatory, it's HNF1, there is the beta-catenin. The follow-up of this lady usually depends on the subtype. You know, is it inflammatory? Is it this beta-catenin that can be? And they mainly biopsy it, looking for the beta-catenin subtype, because like even if it's inflammatory with beta-catenin subtype, if it's just a small lesion in there, they might resect actually this segment of this portion of the liver, do like wedge resection or something like that. But yeah, I mean, in our practice, we like in our section, we usually do biopsies for the adenomas to know the pathologic subtype.
Okay, some people is asking for more talk in future. Please.
Sure. Yeah, sure. Yeah. You just text me like you do, Islam, and I will anytime.
Okay.
Yeah.
Thank you. Any more questions?
دكتور وسام مصطفى، لحضرتك أي تعليق يا دكتور وسام؟ دكتور وسام.
Thank you, Dr. Hisham. Thank you, Dr. Ines, for very informative lecture. I just asking about the biopsy of adenoma. Is it as a malignant? If it is pre-malignant lesions, we do biopsy and we don't fear from any seedling as we do it for HCC, or it is important for us to know the diagnosis.
It's important to know that diagnosis, and if there is malignant transformation. So again, maybe I didn't stress on that. The inflammatory, the HNF1, which is actually kind of 80% of the adenomas, it is very rarely pre-malignant. Actually, these ladies come back for imaging, mainly for the hemorrhage. Like it's more likely to bleed than it is to have HCC. The one thing that we want to biopsy for is actually the beta-catenin subtype, right? Just to know if there is mutation in this adenoma or not. Okay, and of course, what they do with her is that if she's contraceptive, she stop the contraception, and if they are in steroid, they stop the treatment and all that. Like, what's causing it, you know? But the main reason for biopsy is actually the beta-catenin. And then when she comes back for follow-up, okay, you have to, as a radiologist, to say it has markedly increased in size and there is washout. I am worried that this thing is actually turning into HCC. There is malignant transformation in there.
Okay, thank you, Dr. Ines. My work is as an interventional radiology. We just be careful with the adenoma. We don't biopsy if it is diagnosed by imaging, or if we go for surgery, or if we go for treatment. We just go for it and stop. We didn't. We go more for it. Yes.
But you do follow up, right?
Of course.
Yeah. Okay, fine. I mean, I think it depends on the practice you're in,
of course, according to the patient and the history and the diagnosis, of course, as you see.
Exactly. Just I agree with that. Yeah.
Thank you.
You're welcome. Thanks.
Dr. Ines, I just want to ask you about the coexistence of focal nodular hyperplasia and adenoma.
Yeah. See,
it's a dilemma.
Yes. So actually, when you look at multiple liver lesions on MRI, it's not usually this one lesion in there. You have to actually examine every lesion separately. Like this can be a focal nodular hyperplasia, but the patient also has adenoma, or the patient also has cyst. So you have to interrogate each lesion separately. And yes, FNH, of course, can coexist with adenomas, and that's why we send these patients to do EOVEST. I know it's as I've been told, it's not used, but what we do is, I think this is focal nodular hyperplasia. Just make sure give the patient EOVEST, and it's going to show you if it's really FNH, because FNH is just let go, don't do anything, it's done. Like, we don't have to bother around it. No follow-up, nothing. It's done. The same for hemangiomas and cysts and stuff.
So the approach is to assess each liver lesion separately.
Exactly. Each liver lesion has to be assessed separately. You know, even if a patient, let's say a patient with breast cancer, and they saw something on CT and they want to see, is this lesion, like she has lesions in the liver on CT, we send her for MRI and we interrogate each lesion separately. You know, this can be a cyst, but next to it is metastasis, right? So yes, each lesion has to be interrogated separately in the MRI of the liver.
Thanks a lot, doctor.
Thank you. Thanks. Yes, I think somebody asked me a question. Yes, EOVIST is a totally separate study. It's like what we have like in our protocols, the routine liver, which is the MAGNIVIST, which is 99% of the cases. EOVIST is just problem solving. So we give it instead of the gadolinium to solve a certain problem, like focal nodular hyperplasia. Sometimes patients who went for ERCP and they have a fluid collection or cholecystectomy and there is a fluid collection in the gallbladder fossa. They want to know if this is bile or not. We give them EOVIST, and if that collection has contrast in the hepatobiliary phase, then it's definitely bile.
Any more questions? دكتور هشام, you are muted. يا حاج ممكن تفتح الميكروفون لو سمحت. اوكي. اعتقد دكتور هشام. Dr. Ines, I think we don't have more questions.
Just another question, Dr.
Thank you so much, Dr. Ines, for this excellent lecture. Share us again in another session.
Thank you. Thanks a lot.
LIRADS. What about LIRADS? We don't use LIRADS a lot in Egypt. We generally tend to describe the lesions as we see it in the CT or MRI, and we don't give it a LIRAD.
See, there is like the LIRADS, the PIRADS, the TIRADS for the thyroid, PIRADS for the prostate. It's kind of a common language between us and the clinicians, right? So I am telling him it's a LIRADS 3. So it's kind of like, what is, so now I'm telling him, he knows as soon as he read LIRADS 3, he know that the chance of me thinking this is malignant is like 5 to 10%. So what are we going to do? We're going to do the follow-up. If I tell him it's a LIRADS 4, then he knows that it's 75% as a radiologist. I think based on imaging that this is HCC. So he's going to go for biopsy. If I tell him this is LIRADS 5, usually what happens is it is HCC done. We're not going to talk about it. I know it's HCC, no biopsy, no nothing. You go ahead and treat as HCC. So it's kind of, LIRADS is a common language that we hear, we have to implement it. Like whenever you see a cirrhotic patient, once you know this patient has history of liver lesion, there is an observation in the liver, it's a must. We have to apply the LIRADS. Same thing like when you read the prostate MRI, PIRADS. It's a common language between me and the urologist is how worried I am about this lesion being cancer and what is the next follow-up.
Is there a reference for training for LIRADS? Because it's more difficult to use the lexicon, not the final LIRADS. Mass observation.
Yeah, I mean, quite frankly, I can just use a lesion, in general. Yeah, I know in the paper, they are all talking about observation. This is like oncologist word, but I usually say a lesion. There is this arterially enhancing LIRADS 5, and quite frankly, in my impression, the way I say it, 5 centimeter LIRADS 5 in segment. We all understand what I'm talking about. I don't have to say more than that. And in the when I'm describing it and say there is an arterially enhancing lesion with washout, it's like, of course, the measurement. There is washout on the portovenous phase. This thing looks like T2 slightly hyperintense, T1 hypointense. There is diffusion restriction. All this stuff. Okay, but in my impression, I would say LIRADS 5, like let's say 3 centimeter LIRADS 5 in segment 2 of the liver. done. We all understand what I'm talking about. It's just like a common language between all of us.
Oh, okay. So I think it depends on where you are practicing, because Toledo Institute, because at Duke they use observation 1 and they start to describe it observation 2. So
Yes.
it doesn't make difference. It depends on where you are practicing.
Exactly.
And yeah, okay. Yes.
We have like these templates. Each system have a template, and I know actually in MD Anderson, and they use like this very strict observation 1, observation 2, observation 6. It's very good, but in my practice we are more like we describe it how it looks like in each one, and then we give the LIRADs. Yes, and observation is actually what is used in the original paper. Observation is kind of like the more official, if you want to use that lexicon. Yes.
Okay, so thank you so much, and احنا عايزين نشوف حضرتك تاني طبعا ان شاء الله.
ان شاء الله اكيد ان شاء الله.
اوكي. دكتور هشام،
شكرا جزيلا
حاجة؟
دكتورة ايناس. شكرا جزيلا دكتورة ايناس، يعني كان لينا الشرف النهارده ان حضرتك تشاركينا ان شاء الله. اتمنى يعني لو حضرتك تشاركينا مرة ثانية ان شاء الله. ممكن
اكيد
اسلامي نصر
text وان شاء الله. خلاص انا already I have the next lecture, just tell me when.
Okay, ان شاء الله حضرتك هبقى ان شاء الله I'll tell you. Okay, so I think you'll busy with the match maybe.
الماتش هيبتدي احنا المفروض هنبتدي الماتش الويك اند اللي جاي، وبعدين انا الاسوشيت بروجرام دايركتور، فهتبقى هيصه شويه، بس ابعت لي السكيدجول بتاعك وهنشوف.
Okay, thank you so much. Thank you.
شكرا جزيلا دكتورة ايناس. شكرا جزيلا. شكرا جزيلا لحضراتكم جميعا. ان شاء الله نلتقي الجمعه اللي جايه ان شاء الله. طبعا الجمعه اللي جايه ان شاء الله الدكتور إليوت فيشمان معانا ان شاء الله، يعني ان شاء الله يكون يوم جميل ان شاء الله. شكرا جزيلا دكتورة ايناس. شكرا
شكرا جزيلا. شكرا لكم جميعا. السلام عليكم.